Okay, so here is a review of these questions related to the wounds and related to other systems. So we have a little bit of integumentary, we have a little bit of other systems. So first question, 55-year-old male with history of diabetes, plantar ulcer on the metatarsal head. It has a punched out appearance, minimal drainage, no signs of infection. Pain in the area. Oh, no pain. I'm sorry. No pain in the area. What is the classification? Because your patients who have diabetes can have both arterial and neuropathic ulcers, we typically will kind of focus on these two. I mean, your patient with diabetes could have any of these, but that's the ones we think about because of the lack of blood flow. Due to the breakage of vessels, because typically your diabetic patients are having a hard time with their blood circulation, with the use of energy from the blood. Things start to get messed up everywhere, including all the vessels. And then if we think of the part of where they're typically or can be overweight and have, issues with their nutrition, then we always go towards arterial or neuropathic, right? They both look very similar in terms of the punched out appearance, in terms of the dry skin, in terms of the lack of circulation. When you're trying to separate between the two, arterial and venous, arterial and neuropathic, typically the neuropathic ones are going to be in the bottom of the foot. So the key words here are plantar ulcer. So they're diabetic. They have a plantar ulcer. That means bottom of the foot. And then it has that typical appearance and no pain, which means they probably have lack of sensation. So bottom of the foot, I think of neuropathic. Top of the foot, then I can go more towards arterial. But because it's giving you the diabetes, which a neuropathic ulcer is literally happens in our diabetic patients. And then the plantar part of the foot. So for this one, we're looking at burn classifications. And the answer for this one is going to be A, superficial. Red, painful, blanches with pressure. There are other burn classifications that may use the word red or white, right? When we think of partial thickness, that could be red. When we think of, superficial partial thickness, that could be red. When we think of deep partial thickness, that could be more whitish. But because it says red, painful, and there is no open skin, that is the key thing that I looked at there. No blistering, no open skin, especially the no open skin. That's telling me that it's superficial, okay? Your superficial A, meaning not superficial partial, superficial, okay? Superficial is the only one that would have no open skin. The other ones would have open skin because they're going into the layers of the skin. And then your superficial partial thickness, superficial partial, is going to typically be more reddish in appearance. It's going to be painful also, but with open skin. And it's probably going to have blisters, which this one says there is no blistering, so it's not B. And then deep, usually they say it's more whitish. Sometimes they say leathery, waxy, shiny, stuff like that. But actually it becomes less painful or not as painful because everything is so damaged that the sensory organs are damaged too, and they can't really feel pain. Also the same with the full thickness. So it wouldn't be those in this case. For this one, anytime I see heavily exudating, I want to pick my most absorptive option when it comes to dressings, and that is always alginate. Okay, alginate out of all the options is like the one that can take a whole lot of drainage. Okay, so heavily exudating is the key terminology here, and that's going to be alginate. The ones with the word hydro typically are wounds that need a little bit more moisture. And if it's exudating, it's pretty moist. If it's a venous ulcer, it's probably pretty moist. So we don't need as much moisture. So we're going to take out our hydro options. And then the transparent film, it does not absorb anything either, because it's almost like a plastic sheath, right? Like a film paper. It's film, right? Film paper, like it's like that plastic covering. So it doesn't absorb anything. So it would not be good for your heavily exudating wounds. Wound dressings are not going to be as emphasized in your mocks, but they can be there, only because, again, this is considered a more specialized area, and they're kind of shying away from this. But this is a good picture that can give you an idea of things that you can use, dressings that you can use, the source or the references right there in the picture and in the top of the picture. And it tells you, like, what is the goal, and then what are some of the options you could use, okay? And then again, you can see when it says low exudate, you have hydrocolloids, you have hydrogels, but when you have high exudate, one of the key words there, or one of the key ones, is alginates. And then foams can kind of be in between, but low exudate, you see film here too, okay? And then again, depending if it's deep or shallow, typically promote healing. We want to maintain moisture if it's healing on its own, if it's kind of pretty shallow. Once you start having necrotic tissue towards the end there, you can see that we're going more surgical. We don't even just use dressings to let the body kind of heal on its own. We want to cut all that out and then go into the things that could heal it. So that's some options there. Okay, the answer for this one is D. Use enzymatic debridement and cover with a foam dressing. Now let's think about the reasons why, okay? So A, which is dry gauze, packing it with dry gauze, that's going to lead to wet to dry debridement, right? So it's dry, you stick it in there, and then it could get stuck to things, and then you're going to rip it off, right? Now this injury, it doesn't have infection. It's not as deep where you're like you're going into the body systems, like you see bones and stuff like that. It doesn't really tell you that it's a granulating wound or anything like that, but we can assume so because, again, no signs of infection. Sounds pretty good, sounds pretty like a nice wound, a deep but nice wound. So we don't want to mess things up by doing the dry gauze and ripping stuff off, okay? So that I wouldn't choose A. B, apply hydrogel and cover with and also gauze. If we're thinking packing, we typically put it in tunnels or things like that. It doesn't really say anything about that. Going to option B, hydrogel and transparent film. Again, this is typically something that is a little bit drier when we put the hydros. It has moderate exudate, so we don't really need to add the hydro. That would be more for a minimally exudating wound. And then the transparent film, we know, again, no absorption there at all, so we don't want to use that, okay? And we need some absorption because of the moderate exudate. Your sharp debridement is only needed when you really have a heavily necrotic wound that has that eschar and you need to take that off. And this does not say that. As a matter of fact, it says no signs of infection again, so not cool. And then alginate, as we said in a previous question, more for like heavy exudate. That's typically what you see in the questions, like heavy exudate, a lot of exudate. Severe exudate, something that tells you a lot. It's moderate, I mean, maybe, but, you know, again, probably not the best, okay? So the best is D. The foam dressing is absorptive enough for the amount of exudate you see there, which is moderate. So you do need something that's a little absorptive, okay? And then the enzymatic debridement helps, you know, promote healing as we need. So that would be the best option. Okay, for this one, greater trochanter tells me pressure ulcer, right? They're already identifying that you are on a bony prominence. But either way, the question tells you which stage of pressure injury. So this question tells you it's a pressure ulcer. Now it's just asking you which pressure ulcer. Is it stage 1, stage 2, stage 3, or deep tissue pressure injury? It's a dark and non-blanchable area over the patient's greater trochanter. The skin is intact and there is localized warmth, okay? That to me is a stage 1. Skin is intact. That already tells you a stage 1, okay? The stage 2, stage 3 is going to be the skin is not intact. Now, a deep pressure injury, deep tissue pressure injury, can have the skin intact, but I believe that it's like more purplish in color, okay? Okay, so this is other systems, and this is telling you it's an endocrine system question, so you know, that already can tell you a little bit of what your answer choices are, but they did give you 4 answer choices that are related to the endocrine system, so we still have to pick between those, okay? This patient has fatigue, weight gain, cold intolerance, okay, decreased heart rate, dry skin, brittle hair, and then they have elevated levels of TSH and low levels of T3 and 4. Okay. To me, my first thought is between hyper and hypothyroidism. Okay. Now we have other options in there. We have Addison's disease. We have Cushing's disease. We're going to talk about those in a second. I have a little chart on the next slide. But Addison's disease, they usually say things like electrolyte imbalance, like a hyponatremia, hyperkalemia, a hypotension. So that's not what I'm seeing here with the TSH and T4. T is telling me thyroid, okay? Those T levels, whether they wrote out the word or they wrote TSH, I believe that's thyroid stimulating hormone. So I think your boards doesn't use the abbreviations, they write the words, but still, even if you don't have the words, I see all these T's, I'm thinking thyroid. Addison's disease, if I remember correctly, it's like the adrenal gland or something else that's not the thyroid. But T's just go thyroid to me, right? So that's where I'm between A and B. Cushing's disease is about cortisol, okay? Again, not thyroid. And they do have the weight gain that you see here, so I think that's supposed to be a distractor. But again, there's other things that they'll mention about the cortisol and stuff, and they don't mention that. They mention these T levels, TSH, T3, T4. So thyroid, right? We're gonna pick between our 2 thyroid options. You have hyper and hypo. The good thing about them is that, like I always like to tell students, once you learn one, you could kind of figure out the other one because it's almost the opposite, right? If we're thinking the thyroid system, which is the one that controls your metabolism in your body. And why do we have metabolism in our body? To see how our body uses the energy from food, right? If we have high metabolism or good or faster metabolism, typically We can really pick up the energy from food. We absorb things pretty quickly, stuff like that, right? And then hypo would mean low metabolism. Okay, so hyper, with the ER, high metabolism, hypo, low metabolism. Because we are in the endocrine system and other systems, we are thinking literally your metabolism, like how you work with food and energy use. So if you think of somebody just in your life, maybe they don't have hyperthyroidism, but they have a high metabolism, right? What do they look like? They're typically very thin. They typically maybe expend a lot of energy, you know, like, and then that's gonna have, you know, increased heart rate because they're like energetic, right? They have high metabolism, so they really get that energy quick, and they're full of that energy, and they kind of use that energy quickly, and everything is like right? So you'll typically see the opposite symptoms, like instead of weight gain, weight loss, instead of cold intolerance, heat intolerance, instead of decreased heart rate or bradycardia, you'll see tachycardia. So they'll see anxiety, like you'll see like this, right? That would be your hyper. But this is saying fatigue, weight gain, cold intolerance, decreased heart rate. So everything's like, oh, slow, sluggish. And so that makes me think of hypothyroidism. So here's that chart that I was talking about, kind of compares those options there. When it comes to endocrine system, when it comes to endocrine conditions on your boards, I mean, this is it. These are the ones you got to know. Besides, of course, diabetes, you definitely got to know diabetes. And then I'll throw in cystic fibrosis because it's technically an endocrine system issue, even though we put it in the pulmonary category. So once you kind of know this stuff right here, you're pretty good. It helps compare all of the hypothyroidism, hyperthyroidism, Addison disease, Cushing's disease, what hormones are associated. Is it your thyroid stimulating hormone, or is it cortisol? Things like that. And then it compares the metabolism, compares the weight gain or weight loss, compares temperature stuff, right? Like, do they have heat intolerance? Things you may see in the skin, hair, the heart rate, the blood pressure, GI things, GI system issues, mood, and then other things you may see, other signs like goiter, which is that big neck kind of ball that happens with hypothyroidism. If you see exophthalmos, which is right here in the other signs of hyperthyroidism, always connect exophthalmos with hyperthyroidism. My brain just automatically is like, that's it, right? Like that's really the only time we'll ever talk about exophthalmos. And it does specify in Graves' disease, because Graves' disease is hyperthyroidism, right? They're the same thing. So that's another good keyword there. This one is related to the GI system, okay? And it's about GERD. It's specifically mentioning that they have GERD. And basically, what do we do, right? What do we do with this patient, or what should we not do with this patient? And the answer is A. Okay, again, they're having stuff come up, they're having acid come up, they're having food come up. Laying down is going to make that worse. They have to sit up, okay? And then when it comes to physical therapy, we can't fix their GI issues, right? We can educate and we can modify stuff, but the points of education and the other options, increased fluid intakes, that also makes GERD worse because it makes more pressure in the stomach, so that will make more stuff come up, because you're full of liquid and it'll make your stomach fuller, and then more stuff will come up, and it gives you a little bit more heartburn and stuff when you drink a lot of water. You're not going to go prone, because that goes back to why you're putting pressure there, right? So prone is just as worse as bad as supine. And there's no reason to make them do less exercise. We like exercise. We don't really tell them not to do that. It's not contraindicated. Yeah, can you sit there and be like, well, maybe it could make things kind of come up? Yeah, I mean, you could very indirectly, but again, we're in physical therapy, so we need them to do activity. So it's really more about how can we modify the activity. If it said like take more breaks during aerobic, maybe, but it just says decrease, like do less of it in general, and we don't like that. We like aerobic for your overall health, okay? So really, when we're thinking of GERD and physical therapy, which again, it barely relates to us in terms of what we have to know about it. We just kind of have to know what it is and how to modify our sessions. It's really going to be about like just be careful putting pressure in the stomach area, right? So we don't want to lay them flat too much, especially if they just ate. Wait at least 30 to 60 minutes after eating before laying down. Maybe put them in reclining position. Maybe put a wedge, whatever, right? Try not to do too much pressure stuff, whether it's Valsalva, whether it's, like not thoracic, lumbar. Why am I using these words? Abdominal, that's what I meant. Abdominal stuff, like too much pressure. Again, if we have to, because that's part of their therapy, okay, but we have to maybe not do it right after eating, right? Like we have to modify that to not do it right after they eat. Or maybe try to go in a way where it's not as much compression. Prone is going to make things worse. I mean, if you have to do prone, maybe put a pillow, a donut, something so that it could kind of take a little bit of pressure. But, core exercises, you got to be careful with, again, that pressure. Keep breathing, again, to make sure that things are low and slow and calm and not as much intrathoracic pressure, especially while they're exercising. That goes back to the Valsalva. And then education-wise, I mean, you could just be like, hey, try not to eat before you come to therapy. Try to eat smaller meals instead of bigger meals. Stuff like that. Okay, so different types of incontinence. You should know these types of incontinence. Urge incontinence is the patient has an overactive like sphincter muscle, and so it keeps like squeezing and squeezing and squeezing, and then little bits of urine come out because it's constantly like compressing. So your detrusor muscle, which is the one that controls the sphincter, should be like working, but not contract, relax, contract. It should be just holding. And then when it needs to squeeze, and your mind and your brain says it's time to use the bathroom, we need to squeeze, then it works. But if it's constantly squeezing, then it's going to start letting stuff out. So that's urge. Overflow is that your muscle is actually weak, your detrusor muscle, and so it's not holding stuff in, and your bladder becomes super full, and then after a certain point where it's so heavy, it just comes out because it's overfilled, right? Stress incontinence, which is the answer to this question, typically happens when there's some type of pressure in your abdominal intrathoracic area, and that's going to be jumping, sneezing, laughing, heavy work, heavy lifting, exercise, running, like stuff like that. That's going to just create that constant pressure, and again, you have this weak detrusor muscle or sphincter muscle, so it's not really holding it in like it's supposed to. And then functional incontinence to me is the easiest one because it's not even about your bladder, it's not about your sphincter, it's not about anything. It's just really that the patient has other physical issues where they can't either get to the bathroom on time or undo their pants or pull down stuff or unbutton things or take off their belt. So that's going to be functional incontinence. This one, okay, the system we're looking at here, or the answer is going to be lymphedema, which is going to be your lymphatic system. But what are the key words? History of lymph node removal, right? That's already telling me lymph something. I mean, you should make that connection. Now, let's say they took off that part. They didn't say nothing about the lymph node removal. It just said your patient had cancer. Your patient has the heaviness in one leg. It does specify swelling in one leg, the left leg, okay? It started swelling, it's increasing, it's heavy, and they have cancer. But let's say they didn't take out the history of lymph node. A lot of times when we treat cancer, we also connect cancer to lymphatic system, lymphedema specifically, because when you treat the cancer, there's really only two things you could do. Well, not two, but the main ones that they typically do. Radiation, okay? I mean, they could do chemotherapy too, but we're not going to talk about chemotherapy. Two big options, radiation or surgery. They're going to try to cut the breast off, cut the thing off, whatever is the thing that has cancer, they're going to take it out, right? Surgically. So typically when they either do radiation or surgery to those areas, they kind of take out everything around there because the cancer could have spread to a few areas. And sometimes they take out the lymph node. They cut the lymph node or they damage the vessels around there because they're kind of cutting into everything and removing a whole bunch of tissue. And so that's going to lead to that cause of lymphedema. Especially if it says one side swelling, it either has to be a localized injury to that side or lymphedema. If it's something systemic like a CHF, that's not going to be one side. That's going to be the whole body or both legs or something symmetrical. But if it's asymmetrical, then it's probably lymphedema. Oh, and we moved on to the next question. Type 2 diabetes, numbness and tingling. That tells me neuropathy. Okay, these are all diabetic issues or things that are related to diabetes. But the numbness and tingling, that's nerve signs. A1A, right? Like clear nerve signs. Retinopathy, B, is your eyes, your retina and your eyes. So that would say they have some type of eye issue. Nephro, that's your kidneys. Anytime you see the prefix nephro or the root word nephro, that's going to be your kidneys. So that's going to say something about the kidneys or urine or urinating, something like that. And PAD, it has to do with your blood vessels. So while a patient who has PAD probably also has nerve issues and also has diabetes and they're all kind of connected, you really want to be specific to what are the definitions of these things. And this is a nerve pathology or nerve condition, which is neuropathy because of the numbness and tingling.